So anyhow, we'll go ahead and get started. Let's see. How do I? Like I said, dengue it's pretty ubiquitous. There's dengue and dengue hemorrhagic fevers, and they are an acute viral illness transmitted by the Aedes mosquito. And if you compare that to, like, say, for example, malaria, malaria is a protozoal infection. This is a viral infection. And they're both, of course, transmitted by a mosquito, malaria being the Anopheles, and this is the Aedes mosquito. I'll start off right off the bat. Can somebody tell me what's another illness that is transmitted by the Aedes mosquito? And in fact, you can get concurrent infections with the bite of this mosquito.
Urban yellow fever.
Right. Yeah. So that's right, yellow fever. So we have to. So it's possible that you can actually acquire both. So think about that. This is the vector for both.
And when I say urban, as differentiated from sylvan, is that the yellow fever usually goes on as a sylvan infection in the treetops and the top layers of the canopy in the jungles, and between those treetop dwelling animals, namely monkeys and the mosquitoes that are up there, which are a Sabites mosquito, so it's a different one.
Okay.
Comes down to the jungle floor when people go in and do slash and burn and bring the tree down and the mosquitoes with it.
Right. In regard to dengue, you'll often refer to it as breakbone fever. And if you've ever talked to someone that's had dengue, you'll know why it's called breakbone fever. Like, for example, I know Betsy Ledoux had it, and it literally, it's like influenza on steroids. It's severe myalgias and arthralgias. So if you see that in the right context with fever and this diffuse aching syndrome in an endemic area, think dengue. It is the most prevalent mosquito-borne viral disease. So like I said, if we engage in international work, as we are, we're going to see this. It's quite common. As I've listed here, you can see annually over 50 million cases, and that's probably a very conservative estimate, actually. I read some material that some experts expect that actually it's a lot higher than that. So it's very prevalent. It's out there. Between 1960 and 2010, they suspect that it increased 30-fold. And there's multiple reasons why, certainly, and I've listed some of them there, but urbanization is certainly one of them. As Tom alluded to, this is predominantly an urban-related illness, as the Aedes mosquito, it likes stagnant water that you often will find with urbanization. Population growth has certainly contributed with the explosion in the world population. That certainly contributed to the increased incidence. Good morning.
Good morning, Dick.
Of this illness. And then also the world's it's just a greater melting pot. I mean, we see people traveling all over the place now, and so that exchange of persons in contact with the mosquito certainly contributed. And then certainly if you believe our friend Al Gore, global warming has been a contributing factor as well. Certainly, the Aedes mosquitoes you'll find it in equatorial regions especially.
The other thing about Aedes, so that if you happen to be in an area where you've got a dengue outbreak going on and you want to try to control the Aedes mosquitoes, you just need to tell the local population to go around and dump out there what we call container breeders, and anything that holds a small amount of water, a few milliliters of water, they will take in. They breed very rapidly in it, and the biggest thing that we talk about here in the U.S., of course, is spare tires and tire dumps.
Right.
But in other places, like in Haiti, the discarded plastic containers, are are big, especially after a flood will float those things and then leave them and leave little bits of water inside them.
Yeah.
And you get an enormous outbreak of the Aedes mosquito.
Right, and that's exactly right. I mean, if you look, there's containers, like especially in urban areas, I mean, there's just multiple ideal little containers that is just a perfect breeding ground for the Aedes mosquito. So that's certainly been a big contributing factor. And in fact, we'll talk more about that for vector control. We'll talk a lot more about those containers in just a few moments. This is just a map. Like I said, it's you can see that it's largely follows the kind of equatorial regions there. And I've got two different geographic colors there. The red is, and these are, I should add, this is with 2006 data. But in the red, you'll see both where there was epidemic dengue as well as the vector, the Aedes aegypti mosquito. There's a number of various subtypes of this Aedes mosquito that will transmit dengue, but that's by far and large the most common one. The Aedes aegypti. And then in the blue is regions where there wasn't outbreaks of epidemic dengue, but the vector was there and the possibility certainly exists. So.
This year, I've been following, and it's been a really particularly bad year, and it was in Central and South America for dengue. It's still going on in Bolivia right now.
Right.
And it is also now spreading into and becoming several of those blue states in Africa. If you looked at data this year, would be red.
Okay, right. Yeah, I've read a lot about dengue, and like you said, in particular, Bolivia has been
last year they had a few cases in Florida as well.
I've
creeping on up.
Yeah, I've read, and I think as we said, with increased international travel, we're going to start seeing a lot more tropical disease in first world countries like the United States. Unfortunately, I think we'll certainly see more of dengue and perhaps even malaria. Hopefully not, but it's a real possibility.
Yeah, it's just so big high there. It's down in the it's below the altiplano. Yeah. You ever had it? You ever had it? No, unfortunately. My daughter-in-law has. She was pregnant for 5 years.
Just before you walked in, Dick, I was just saying, that the one of the common slang terms is breakbone fever, and if you've ever talked to someone that has had it, it's a very appropriate name for it, because I called it like a influenza on steroids. So they have profound myalgias and arthralgias with it. So going on then, as we've already alluded to, the etiology of this illness it is viral. It's the dengue virus, and it is the genus flavivirus. Not coincidentally, the yellow fever virus is likewise a flavivirus, and as I said, the Aedes mosquito can transmit both. So it can, and certainly that would be very possibly catastrophic if you were to acquire both. Interestingly, there is 4 serotypes of dengue virus, and I've listed them there, dengue 1, 2, 3, and 4. And the interesting thing about it is there's very little cross-protection among the 4 viral serotypes, and we'll talk about that further in detail. But in summary, all I'm saying there is, unfortunately, if you acquire one, it really doesn't protect you towards the other. In fact, and we'll distinguish between primary and secondary dengue infection. Primary tends to be milder, and secondary tends to be more severe. So people that are indigenous to regions with endemic dengue, they're more likely to get more severe dengue, and in fact, dengue hemorrhagic fever or even dengue shock syndrome. So multiple infections are not a good thing. It does not protect you like many illnesses. I'd say, for example, conversely, people with malaria, they tend to weather the storm better with multiple infections, and the converse is true with dengue. So just looking at the vector a little bit closer here with transmission, I just wanted to show a picture of the Aedes mosquito there just so you could recognize it, and there's some very distinguishing features. I wish I had shown you, it's a really small mosquito, so I wish I had given you something to compare it to, but the mosquito, it's quite small, and as you'll see, there's some, and I'll turn here to the next slide, I'll go back in a minute. There's some, as I said, some distinguishing features. There's black and white stripes on its torso as well as its extremities, so that's a very distinguishing feature. One thing that's difficult about dengue and the mosquito is, as we know, the Anopheles mosquito and malaria, it tends to bite at dusk and in the evening. Well, unfortunately, this mosquito tends to bite during the day. And so that's a real problem, as we'll talk about further, because it's a lot harder to control the biting with dengue than it is malaria because of that fact.
Yeah, the nets don't do any good.
Exactly. Yeah, you're stealing my. Exactly. That's exactly right. Obviously, the mosquito nets that we use at night are not going to be nearly as effective because of that fact. It's always the female's fault in malaria and in dengue. It's the female that they're the only ones that they need the protein in a blood meal to properly produce the eggs. And so they're the ones that bite and transmit the disease. The males are innocent, and they feed on plant nectar. And as we've talked about, and we should talk about and emphasize, the females, they lay their eggs in sources of stagnant water, in these small pools of stagnant water. So I just want to go back one more time. And so there it is. As I said, it's very small mosquito. Tom, would you say it's smaller than the Anopheles mosquito?
I think about the same size, but it's larger than the Culex.
Okay.
Culex tarsalis looks exactly like this guy. The picture we got on the screen, but it does not have the stripes out on the appendages like that.
Right.
But yeah. Okay. The other thing about the male and the female, so you're wondering, why does that make a difference? Was because the female is the only one that bites. The male, if you destroy him, then you're destroying the source of the sperm and cutting down on the number of females. But that female, she does not have to have water to lay her eggs. She can lay her eggs in a dry container as a little bed of the eggs. They call them a float, and it just sits there and waits until water comes along before they hatch out. And they can last several months in that state, waiting for a rainfall or something so that they can hatch. So once you get the rainfall come or a flood, Aedes will be abundant very quickly because the eggs are already there.
Wow. Okay, I didn't know that.
Yeah.
In Comores, they are coconut shells.
Yeah, exactly.
And
wow.
the banana palms.
Yeah.
Yeah, like I said, there's all kind of perfect little containers. I hadn't thought about that, but that would make sense. That would be another perfect breeding ground for. So I'll just show them with the arrow there. I mean, the very distinguishing black and white stripes on the torso and the. Oh gosh! Whoops! I got running as I got here. All right, we'll click and hold if you want. All right. How do I get rid of that? Just go to the next one. Okay. So, going on in terms of transmission, this is interesting, an alternative mode of transmission that it actually can be transmitted via blood products and organ donation in countries where it is endemic and they don't just routinely check for dengue, that it can be transmitted in that fashion. And actually, I didn't write them down, but I believe it was, I had some statistics on Somalia, and they were impressive. The number of, like for every, like for example, a packed red blood cell, unit of packed red blood cells, they listed, I can't remember the statistics, but it was pretty high. So, and then also another alternative mode of transmission is vertical transmission, where the mother can pass it on to her child during pregnancy or perinatally. So it's not just via the mosquito, but that's by far and large the most common way that it is transmitted. So just looking at the incubation time, remember I told you, I think I said this, and I'll say this over and over, it just seems like to me incubation times, they tend to be 1 to 2 weeks,
yes,
with many, many diseases. So you can impress your friends with dengue and ask you, well, do you know the incubation time for dengue? And if you say 1 to 2 weeks, you'll be pretty close with a lot of illnesses. So you can impress your medical friends with that fact. But that is true with dengue as well. It's about 3 to 14 days. And coinciding with that sort of classic teaching, a lot of times we, in this line of work, and Tom and I have experienced this, we have a lot of travelers that return and they have some mystery illnesses, if you will, and we have to determine what it is. But if you have a traveler that returns home with fever and symptoms that present greater than 2 weeks after returning home, it's not going to be dengue, just based on the incubation period, or it's likely not to be dengue. So I should say likely. There's very few things in medicine that are absolutes. That's another thing that you should remember.
biological variability.
Yeah. And then one other fact is that most persons that are infected, in fact, they say about 3/4 of the persons that are infected with dengue, they're either asymptomatic or they have very mild symptoms. In fact, a lot of times people will attribute it to like a mild gastroenteritis or a cold or something like that. By far and large, most people, that's the way they present with dengue.
So you asked Dick if I've had it. I may have had that stage of it.
Yeah, so if we did some serologies here, in fact, I'll bet you anything, if we did some serologies here, in fact, I'll bet you've had it. I'll bet you $1 billion.
They won't take my blood already.
I bet if we did an IgG serology, it would be very positive for you. So
it's better than AIDS.
Yes, sir. Yes, sir. So I'd rather have that. So anyhow. So just looking now at the syndrome, and like the one thing that makes this tough, like a lot of these illnesses that are similar to dengue, is the symptoms are very protean. In other words, there's a lot of variability in the presentation of dengue. So you have to have a high index of suspicion. And it's really in classic dengue. You'll hear me refer to during this discussion. We'll be talking about classic dengue. And then we'll be talking about dengue hemorrhagic fever, which tends to be with secondary infections. And then we'll be talking about dengue shock syndrome, and that tends to be like when they get like dengue hemorrhagic fever, and then they get very severe, and they get a lot of vascular permeability and vascular collapse, and they get shock syndrome. And we'll talk a lot more about this. But these symptoms are more associated with classic dengue. You'll see a profound headache that they'll acquire once they become symptomatic. And typically they'll describe it as a retroorbital, that the pain, the headache will be predominantly focused behind the eyes. So that's classic dengue. And associated with this, and coinciding with the name breakbone fever, again, you'll see severe aches and pains in the joints and the muscles. And then about half the persons with classic dengue, they'll get a rash, a macular-papular rash that looks a lot like measles. So that's part of your differential. If you're in a country with that has endemic measles, you've got to think about that as well. But the rash looks a lot like measles. I'll show you a picture of that in just a second. And then you can get a lot of GI symptoms with dengue and or respiratory symptoms. And so that'll really, again, if you don't maintain that high index of suspicion, that'll really throw you off. So you could have predominance of GI symptoms like nausea, vomiting, diarrhea. So that's really going to broaden your differential. So that could make it tough. Malaria can do the same thing, and certainly there's a number of viral and bacterial gastrointestinal illnesses that can do the same. So sometimes it'll be tough. And then sometimes you can have, like I said, a predominance of respiratory symptoms too, much like measles, where you get sore throat, cough, nasal congestion, sort of a coryza-like picture that you can see with measles. So that's something that you need to remember with dengue. Here's, I don't know how good that's showing up. It's kind of not real distinctive, but you can see a real fine diffuse macular-papular rash on this gentleman's torso. And again, that looks a lot like measles. And
Lance,
yes, sir.
You got that with hemorrhagic fever. Are these
That was just the title of this whole presentation. Okay. That is dengue.
But that has nothing to do with the spots, not like
no, sir.
meningococcal.
No. Now that's a distinction that I should make. I'm glad you asked that question. So classic dengue, you'll get this rash, but in addition to that, and we'll talk about it further in a minute, you can get thrombocytopenia, and you can get coagulopathy, and then you can get petechial lesions in the skin. That's not the rash. So you can see petechia, multiple petechia in someone with dengue hemorrhagic fever, and again, that's not this rash, and it can look somewhat like disseminated meningococcal disease. So that too would be part of your differential if you were referring to dengue hemorrhagic fever, but this is just the rash.
How long does the rash last?
It lasts about 5 to 7 days.
And does it come before, during, or after the hemorrhagic fever?
It would come before, yeah. And again, you typically see the rash tends to be a lot more associated with primary infection as opposed to secondary. So you'll see a lot of cases of dengue hemorrhagic fever without the rash. So you'll see petechia without this macular rash oftentimes. Any questions out there in the stratosphere?
Is there, other than the one spot, is there any difference between this rash and, say, tick typhus, the rash?
I don't know the answer to that. Although I will say this, Dick, we had I'm pretty sure we had a case of typhus a couple weeks ago with someone in SP. And there was several people that got it. So I wish you had seen it because they were together and
in Mozambique.
In Mozambique, or lice, yeah.
There's certain.
I didn't get to check it. I wish I had.
There would have been posts, and we had no.
Yeah, I don't know that it was typhus, but I was very suspicious of it. It certainly was in the differential, but I wish you had seen it.
Give us a sampling.
Yeah, she wasn't discretion. She wasn't enthusiastic about doing that, but I wish she had.
Immunized?
I'm sorry. What?
Immunized? Was she?
No, sir. No. Let's see. Kelly, I believe, is asking, how long do all of these symptoms last, not just the rash? Typically 5 to 7 days. Again, there's going to be some variability, and I'm going to give you the 1 to 2 week answer, but it'd be more like usually 1 week, but there's a lot of lingering symptoms that can actually, Kelly, last for a long time. Like, for example, sort of like a post-mononucleosis syndrome. These people can be fatigued for weeks to several months after.
Yeah. My daughter-in-law had it this time, and it took her a full 60 days in her recovery.
Yeah. So it can be a pretty protracted recovery. Some more signs and symptoms. Again, and I believe I already said this, but with classic dengue, is typically with the primary infection, so like travelers or not persons that are indigenous to the region. And then dengue hemorrhagic fever occurs with secondary or recurrent infections. And according to the World Health Organization, there is 4 cardinal features of dengue hemorrhagic fever that I've listed here. And the real one that I want to highlight is increased vascular permeability. That's what really makes the dengue hemorrhagic fever a real problem. And I don't know all the science behind it, but there is this really increased vascular permeability. So they'll get, these people can get ascites, they can get pleural effusions, they can get edema, they have persistent fever, they typically have a marked thrombocytopenia of less than 100,000, and then with that you can get hemorrhage. And we'll talk a little bit more about that, but classic hemorrhages, I've already said, are very common places within the skin, so you'll see the petechia. They can get gastrointestinal hemorrhage, or you can see hematemesis, or you can see bright red blood per rectum. Women can have vaginal bleeding. You certainly can get epistaxis, or nose bleeding is pretty common as well, so there's multiple sources of hemorrhage. They don't usually bleed from all the orifices, but they can. So I got ahead of myself there. I just talked about that, the various hemorrhages that we see. And then, as I said, dengue shock syndrome can occur in the setting of hemorrhage with excessive capillary leakage, resulting in this diffuse edema that I've already described. And then, of course, you can get into organ damage and then shock and death. And the mortality, and I don't have those listed, and I really don't know them, but the mortality, it seems like I'm going to think, even with aggressive treatment with like wide open dengue hemorrhagic fever and shock syndrome, it's at least like 10 to 20% is the numbers that are coming to me. So it's a very serious disease when it gets to that level. Very rarely you can have some persons that will get liver failure or even CNS involvement. I've never heard of that personally, but I did read that, and so they can have manifestations such as seizures, encephalopathy, so they'll have altered mental status and a comatose state, and they can get a motor weakness too. It can infect the heart, so you can get a cardiomyopathy.
I don't know if you talked to Paul Child, but I think he had some of those symptoms when he was doing it.
Really? Okay. When you say like what specifically? Do you remember?
He had neuropathies and motor weakness.
Okay. I remember that. He did say that. You're right.
Neuropathy. He had some hallucinations.
Yeah. Yeah. So. Yeah, I'm starting to experience that. Actually.
No, right?
Now you don't want.
No, I don't want. As the child at the table says.
And then they even commented on Rye syndrome, which is seen in PAM, is seen in the pediatric population, but they did mention there's some debate in terms of was the Rye syndrome from the dengue or was it from the use of salicylates that they used to treat the condition. So I don't know if you want to speak to that or, but I did see that comment.
Wouldn't it be kind of risky to use salicylates with?
I think so.
Yes, in fact, I'm going to. My slide will say that. I would definitely advocate utilizing acetaminophen as opposed to aspirin or any NSAIDs. There's multiple reasons why it'd be contraindicated, but certainly because of the thrombocytopenia and coagulopathy and propensity to have hemorrhage. So absolutely, I would not recommend it. So in the diagnosis of dengue and dengue hemorrhagic fever, as we all know, in developing countries, the diagnosis is mainly clinical. And yeah, thank you. Yeah, Pam says aspirin is pretty much the culprit, so that is highly associated with Rye syndrome. I don't know a lot about that, but she's exactly right. In developing countries, as I said, the diagnosis is mainly clinical, and that's tough. But at the same time, it's great too because it gets you back to good old bread and butter medicine. Because really, your best tools are truthfully, even in the States, having practiced here in the States for years and years, I'm telling you, your best tools are what people tell you, your history and your physical exam, and it gets you back to relying on that. Those are your best tools despite technology. Now, certainly technology is important, but that remains even in the modern society in the United States and Europe and Canada. Our best tools are definitely those. So some of the other things that you'll see with dengue that will definitely help distinguish it from other illnesses that are similar, if you have access to some simple laboratory assays, you'll get a low white count. And if I'm not mistaken, and if I say something incorrect, correct me, but I don't. Certainly you can see that in things like malaria, but it's far more common in dengue. That's classic. You'll get a leukopenia with dengue, and you'll get concomitant thrombocytopenia, and then certainly you'll get elevated liver transaminases, so you'll have an elevated AST and ALT. Now this is getting a little bit more sophisticated here, but if you did have access, let's say, if you did have access to a sophisticated lab One of the real quick screening tools or assays is an ELISA that you can check. As you know, IgM is an acute antibody, and then later you develop IgG, but you first develop IgM. So you can run an ELISA for an IgM. And as I said, that's sort of, I said confirmation, that's probably not a good word there, but that's a good screening assay. And one thing about that may not develop for about the first 6 days. So if you have the luxury, the second one here, this right here, dengue viral, it's called an NS1 antigen, that'll be positive almost immediately. So if your IgM, ELISA IgM is negative, you can also test that. And then the more confirmatory test, the gold standard is this HI or hemagglutination inhibition test. And that's the classic where you get an acute and convalescent titers. And if you see a 4-fold rise between the acute and convalescent titers, then that hemagglutination inhibition test is positive. And that's sort of been the mainstay, the gold standard in some of the labs that routinely look for dengue. There, I've already mentioned that, so here we go. The acute and convalescent samples should be evaluated concurrently by this hemagglutination inhibition. And if you see, if it rises 4-fold, then indeed that's confirmatory of acute disease. And then if you get really sophisticated here, you can, of course, do PCR for nucleic acid. And actually, I was reading, there's an assay now, a PCR assay for influenza that can easily be implemented for dengue now. And so they just made a comment that you'll start seeing this a lot more available now. So, and then, of course, you can do viral isolation in cell cultures, but places that we're going to be working are field hospitals. We probably won't be doing that.
If you just put a kit for that in.
Yeah, we'll have that in there. That will be for your disposal, absolutely. Yeah, that'll be like phase 2.
I'm doing a American First seminar on dengue fever.
I'm sorry?
Learning. That exciting.
Okay, so just looking a little bit here at the differential diagnosis, and this is a real good exercise. I always like to, I mean, this is critical that we do this, is when you have a case, and I'll just, this is worth throwing out, but when you have a case, sometimes you have a case and you just know it's that. Really do everything you can in your power to refrain from just from zooming in on that diagnosis. So I've always tried to maintain that discipline over the years. Think, okay, what is the worst thing this could be, and what is the most likely thing this could be? And always add 3 or 4 things to it. I always, in fact, a lot of times when I see patients, I'll even say it out loud to the patient. I'll kind of go, as an exercise, I'll go through the differential diagnosis, because you'll get burned if you don't do that routinely. So always think, and this is one, dengue, there's some other illnesses that we'll see pretty frequently that can look a lot like it. So I've already alluded to measles, because the rash can look a lot like it. You can have the fever with measles, you can have the rash, you can have the cough, you can have the GI symptoms. They can look almost identical. So it's tough. So you have to go back to the history and the context. Is there a measles outbreak, or is there a dengue outbreak? Or, you know, these are the things the clues you have to look at. Rubella, we don't obviously see that here because we get routine MMRs, but in some of the, especially like sub-Saharan Africa and some places where they don't routinely get that vaccination, rubella with the rash can certainly look a lot like that. And then just other commonplace viruses, enteroviruses, influenza, or a number of other viruses, I imagine during the acute stage can look a lot like dengue.
Seminar on dengue fever, sorry.
And then certainly malaria is going to look a lot like this. So we have to be real careful, because malaria you can treat and with the definitive therapy, and dengue, of course, as we'll talk about in a minute, you can. Leptospirosis is part of it too, so think about that. I believe Tom diagnosed probably a number of people that had leptospirosis, but they can look a lot alike. And then finally, typhoid fever. Certainly, that you tend to have a lot of GI symptomatology with that. But typhoid with fever, nausea, vomiting, diarrhea, can look like that too. Any other? What about some other?
Typhus.
Typhus, yes, sir. I haven't seen a lot of that, but did you see a lot of it? Probably
experienced it.
Oh, you experienced it. There you go. Okay. Well, I really wish you had seen this lady the other day, but I was suspicious for that. But anybody else? Any other? Rich?
I'm a pretty healthy guy.
Yeah, guy.
You know, the thing that I would urge really to be careful, of course, I'm talking to the choir here, but when we're dealing with things like malarial leptospirosis, you're dealing with potentially lethal infections, and they're not properly diagnosed.
Yes, sir. Yeah.
The malaria, depending on which one it is the rapid lethality of it. Leptospirosis, you know, the thing about it is it looks like it's gone away in about 7 days. You start getting better, but it's the secondary onset that you really be careful of, because it's when you get the CNS involvement and invasion.
Yeah. The teacher learned with typhus because it wasn't recognized.
Yeah. I don't have it on here, but what about yellow fever? Yellow fever, I mean, it can
present a lot like that, but then you get white.
But then you get yellow fever, then you get jaundice. But like I said, rarely you can get. Now you probably won't get nearly as extensive. It'll be more of an inflammation of the liver and not an obstruction with like jaundice per se. But yellow fever could certainly be on here too.
Just as a parenthesis, be sure to keep your yellow fever up to date.
Yes, sir.
I mean, Nairobi is checking for yellow fever if you come out of school.
Yeah.
Okay.
Yeah, that's right. So all you folks out there, make sure that your yellow fever is up to date. Yeah, Heather Barr is our mother of vaccinations here, and she keeps us current on everything, thank goodness. But you guys don't have that luxury, so make sure you keep up to date with yellow fever, because it is out there. In fact, there was an outbreak, if I'm not mistaken, recently in the Sudan of yellow fever.
You know, you may want to look at that for your DART people that are signed up. Their immunization.
Yeah, we're trying to do that. Is everybody out there up to date on their yellow fever vaccines? Kelly, you better get it.
Man, you haven't mentioned at all the impact of dengue fever on pregnant women. Is there any impact on the fetus or anything like that?
I don't know that very well, but if you do, you do.
I know you can get vertical transmission.
Yeah, there certainly can be vertical transmission. I don't know about that, truthfully. If anyone else does, please speak into that. I always go back to, I always rely on, I'm an internist, not a pediatrician. So Pam or anyone else out there, if you know anything about that, about the impact on the fetus in a pregnant woman, I'm sure that it could be significant. I did just write some. I didn't see anything about like risk factors like pregnancy, so I don't know about that. But I did comment here on some risk factors that we can see with dengue. As I mentioned, interestingly, in young children, they tend to be the ones that are most asymptomatic. They have the highest incidence of mild symptoms. However, they're also the patients that can get the most severe disease. So you can see, like, they can get hemorrhagic fever and shock. So we have to be careful with our young children that are indigenous in the area.
You know, Lance, did you see differentiation between the U5s and the over 5s in that data?
No, sir. I don't know about that. And then sort of counterintuitively, they stated that it was more common in children that are relatively well-nourished as opposed to malnourished children. So I guess that would provide some protection to a lot of these kids because they're certainly malnourished. And then females are more apt to acquire, for whatever reason. I guess mosquitoes have a predilection for certain people. Have you ever noticed that?
Oh, absolutely.
And I guess the women are just sweeter. Is that what it is?
Yeah. I guess
That is the exception.
So I think it's just that's what it's got to be.
It's a pheromone thing.
It must be. Women are just sweeter, but. And then certainly chronic and debilitated states like COPD, asthma, type 2 diabetes, people that are debilitated are certainly going to be more prone to that. And this, I have no idea why. It said people with a high body mass index. I'm assuming they mean obese people, but I have no idea why that would be, but I did read that. And then this is, we mentioned on this in the beginning, but the virus strain is a risk factor. And what I mean by that is, and we've already touched on this, but infection with one serotype, remember there's 4 of these flaviviruses, but an infection with one serotype produces lifelong immunity to that type. So if you get, let's say, 1, you will have lifelong protection to 1, but it only provides very short, term short-term protection against the other 3 serotypes. The risk of severe disease from secondary infection actually increases if someone previously exposed to serotype 1 then contracts subsequently type 2 or 3, or alternatively, if someone that had or is exposed to 3 then acquires 2. So we can see secondary infection can be a lot more serious. So it actually, this is...
Does anybody use serum treatment or antibodies from...
They don't, but you're alluding to, I mean, they really think that dengue hemorrhagic fever in a primary infection is more related directly to the viral infection, and dengue hemorrhagic fever is a lot more immune mediated. So it would make sense, Dick, that they could develop that, but there's nothing. I'm sure they must be working on that somewhere. Some laboratories are working on that because secondary infection is definitely immune driven. The immune system drives hemorrhagic fever.
Didn't they use, for Lassa fever, they used the immune serum of other people that had Lassa fever?
Exactly. Yeah.
Speaking of Lassa, we still have that going on in Nigeria.
Did you?
Yeah.
Okay. So looking at a poll question then, the best way to control the spread of dengue fever is, and we'll take a poll here, but A, treat patients with the antiviral medication ribavirin. B is wide-scale use of insecticide-treated bed nets. C is elimination of freestanding water containers. Or D, spraying with organophosphate or pyrethroid insecticides. And so we will let you guys...
So if you want, you can use our polling feature, which is located at the top of the participant list. If you look just above the H bar name, you'll see an A with a box around it. You can roll over that and choose A, B, C, or D, or you can just enter it into the chat pod, whatever your preference is. But there you go. Shelley's got that.
If our opinion is going to count, we're going to have to bring an iPad.
That's right. The 6 or 7 of us here in the room want our opinions to count as well, so we'll have to collectively come up with a consensus, apparently. So,
all right, what does everybody in the room think?
C.
And I agree with you. So
that's important.
So that is the correct answer. There is C, and we discussed that. And you know, it's funny. It's something so minor. You think, wow, just eliminating these containers, and it could have a real impact on the transmission of this vector-borne disease. So there are some things that we can do as an organization that are, I guess I'm just making this point, a principle. Sometimes there's some really basic interventions that we can make that can have a profound impact. It doesn't always, in fact, I've always said that I think in life, like if you look at inventions, for example, the most simple inventions are the best. So sometimes the simplest interventions are the best.
Can we carry that on this a little bit?
Yes.
What is probably the most effective means, even better than elimination? What did they used to do?
For dengue? Or for that mosquito?
Mosquitoes. Just a huge airdrop of DDT. Yeah.
Yes, sir.
I mean, that was what, you know, we've saved the dengue bird, but we haven't saved the dengue people.
Yeah.
Well, you know, we now have techniques called ULV, ultra low volume spreading for insecticides, where you can spray a volume of it out from an airplane that you can't even detect, in the environment, and yet is very effective in controlling mosquitoes. And so, with the advent of the ULV and the fact that we found out that Silent Spring was largely a falsehood, that I think we should go back to. We lost millions of lives to that falsehood.
We have.
Yeah.
There's enormous resistance to use of DDT. Now, and there's a lot of controversy here. We could talk about this for a while, but like widespread agricultural use of DDT, maybe there was some adverse impact on on the environment, but really for vector control purposes, it's really they haven't shown, but yet it's really, as Tom said, there's been millions of lives, like malaria. I mean, think about it. There's been millions of lives lost because we haven't utilized that technique.
I truly believe that we not backed away from that malaria would be history now.
It certainly would be, we would be in better shape. But anyway, it's very controversial, and I hope I'm not stepping on some environmentalist toes out there because I know they're out there. So, in terms of treatment, this is a virus. There is no specific antiviral therapy. So ribavirin or whatever, interferon, it doesn't work. There's no specific antiviral therapy, and it is predominantly supportive care. A lot of these people can be certainly dehydrated with, as I alluded to, a lot of them can have GI symptomatology, nausea, vomiting, diarrhea. They can have vascular permeability, so they can have a lot of third spacing and lose fluids that way. So ORS or people that are real severely ill, intravenous fluids. But now you're going to have to be careful with, especially those people with dengue hemorrhagic fever and shock. Yes, your hand is forced to use IV fluids, but as I said too, you can drown these people too with fluids because they have really significant vascular permeability, and they'll get various evidence with utilization of IV fluids. But sometimes their intravascular volume is so low that you're forced to do that. Some of these people certainly can become quite anemic, and so blood transfusions may or may not be warranted. And then, as Dick has already alluded to, certainly I would not utilize aspirin or NSAIDs for analgesic purposes or alleviation of fever, but I would use paracetamol or Tylenol or acetaminophen, all the same thing. So
you've not mentioned the kidneys at all.
They're really, now you certainly could get like secondary dehydration, like rhabdomyolysis dehydration, but in terms of like direct impact on the kidneys, unless you get like a shock syndrome, it doesn't typically affect the kidneys. Prevention, unfortunately, there's no approved vaccines for dengue virus. I know that they are they're working on it. There's been tremendous progress for a vaccination. In fact, and if somebody knows more about this, I know that there is rumor that in the next, I believe that I have read somewhere in the next decade that they anticipate to have an effective dengue vaccination. Does anybody know anything about that?
One that they tested in Thailand pretty much failed. So that was bad, and that was a setback, but there's multiple testing going on. So there's multiple companies that are in different phases of testing. So what I've seen was sooner than the next decade, like in the next 3 years maybe.
Okay. Yeah, I've certainly heard that, and that would be great because there's certainly tremendous morbidity and mortality associated. As I said, a minimal estimation is that it infects 50 million people worldwide on an annual basis, so it's no small disease.
As far as the vaccines, they're making unbelievable progress in molecular biology. For example, the flu vaccines for years, the flu virus is a Y-shaped virus. It has a standard body, and then it has a couple of of arms that go off of it, and for years our vaccines have been made against one of those two arms, and those arms are the ones that mutate. The body of the virus itself never mutates, and so now that they've been able to go in and with molecular biology to isolate out that part of the virus, and they're making vaccines. In the very near future, we'll have vaccines on the market, which will be against all flu viruses, and so it'll be a one-time immunization, against all virus because of that. And I would imagine that the same thing's going on with dengue. We're looking at the molecular level to go down and see if we can find a part of that virus that that we can immunize against. The only other thing about the dengue virus that we have to worry about is that previous exposure and some immunity leads to, a exacerbation of symptoms and disease on subsequent infection. So that, it could be back to the factor, and I forget which one of the viruses, one of the childhood viruses where we immunized a lot of kids, in the past, and they ended up killing them. They died. They got the subsequent infection, died of pneumonia. So really have to be careful when we start messing with a virus like dengue. Is that we're not predisposing to the word, to the storm of disease.
And then the other comment there in terms of prevention is that we really need to rely on integrated vector control programs to mitigate the spread of this disease. So prevention is the name of the game. And I already mentioned, the primary method of controlling the vector is by eliminating its habitat. We've talked a lot about emptying containers of water, which is the preferred method. And then we mentioned insecticides and biological control agents. There's some larvicides and various other agents. I've heard a lot of, for controlling mosquitoes too, you can utilize various forms of oil, just a very minimal amount of oil in the water, not enough to really contaminate the water, but enough to control the larva.
The best thing to use on that for the oil is diesel fuel. Because it can form a very, very thin coat, prevents the larvae from being able to breathe. That's what it does. It puts a film on top of the water, and they can't put up their little, breathing tube. And it stops them from breathing, kills them.
Now, do you know, Tom, I would like to know the answer to this, and I don't know, is like with diesel fuel, I've read a lot about that, but I actually, practically speaking, I haven't seen that implemented. Like in a refugee camp and so forth,
the reason you won't is because in the refugee camp, those refugees are dipping into that water and drinking.
But I read it all the time, but I've never seen it actually implemented.
The only place it will work is on still water, and again with the Aedes, and getting that, you can't spread that much diesel fuel. You can't go out and spray it on the environment. And the reason why you can't do, because it's in containers and it's everywhere. So you just can't do that. The only thing that is effective for is a mosquito that breeds in relatively clear water, and relatively, it has to be still water.
Now there are, someone's raised the question, Shelley's raised the question, what about more biologically or more, I say, environmentally friendly oils, like vegetable oils? I have read about that.
Shelley, what would happen with those, and if you just put a little vegetable oil on top of water and see what happens. It gathers in droplets, and so, it's got a very high affinity, surface attraction for itself. And so it'll gather up in droplets and not spread over. Diesel fuel, on the other hand, will make a nice even 1 or 2 molecule layer of that over the entire surface of the water. It does not.
I have read about there's and I can't recall immediately that some like I said, environmentally friendly oils that are not diesel oil as an alternative, but I can't recall exactly what they are.
What does diesel oil do to you if you drink it? I mean, if you have that thin a surface?
I have no idea.
Well, that's what I'm wondering is, I mean, she's raising a great question because, if you can use something that is not toxic at all in minor levels, but is enough to control the larva, then and that would be ideal.
Well, in this case, you wouldn't control the larvae because they're in all those little containers everywhere.
I guess I'm talking more about anopheles.
Yeah, like
mosquito.
anopheles.
Yeah.
Yeah.
But
the other thing is that you know, as we're talking about mosquitoes, people. I just read something recently where it says stagnant water. You know, that for anopheles, anopheles don't like stagnant water.
right.
They don't like organically rich water.
Right.
Anopheles breed in nice clear ponds that are biologically, as we would say as an environmentalist, they're healthy ponds.
Right.
And they breed in those.
Yeah.
Healthy punch with unhealthy.
Yeah, right.
So I just made a comment there. I just said, that this is the preferred method just because, like I said, because of all the resistance to the use of insecticides by environmentalists. But I think there's a very appropriate place here, but that remains a debate. And then in regard to preventing mosquito bites, and this is especially important for dengue because, as we alluded to, the Aedes mosquito bites during the day. So it's important that people apply the use of insect repellent and they wear protective clothing. And unfortunately, the temperature in some of these countries it's tough to wear long sleeve shirts and long pants, but the alternative is getting dengue or malaria. So
yeah, there is some. There's a lot of tales out there about the use of vitamin B for reducing your attractiveness to mosquitoes.
which vitamin?
The B complex.
B, yes, sir.
I take vitamin B6 on a regular basis, and I am very rarely bitten by mosquitoes. But I don't know whether, which came first, the cart or the horse, because I don't know whether it's just something about me that I'm resistant. I grew up on fishing, subsistence fishing on the rivers in New Mexico, and going out and setting trot lines for catfish in the late evening hours and early morning hours, and got bitten by a lot of mosquitoes. And so I may have something, of an immune, thing with the mosquitoes. I don't know. I just don't get bitten. But other people will tell you that taking vitamin B complex makes the mosquitoes avoid.
How much?
Yeah, that's
1.5 milligrams a day.
Yeah, I was going to say the only caveat to that is I probably wouldn't recommend any more than 25 milligrams because you can with higher doses. It's fat soluble and it's you can get neuropathy.
Yeah,
That's vitamin B6.
Yes, sir. B6, thyrodoxine. Mm-hmm.
In fact, it's hard to find 25 milligram anymore, so I just break it up.
Yeah. You can probably take 50 too, but I'd err on the side of safety and use 25. But anyway, so just in closing, that's just a quick overview of dengue and dengue hemorrhagic fever. Are there any questions out there? Anybody have any questions? And we're amongst friends, so there's no silly questions. There's a lot I still don't know about dengue, but we're learning it.
You got an epidemiologist sitting at the table, so there really are no silly questions. That's one of our stock and trade is that we ask a lot of questions.
So Kelly wants to know, how often does dengue move to hemorrhagic fever? Is it often or not so much? I don't have statistics. I've read a lot about it. I don't have statistics, but I can just tell you this, Kelly, it all depends on the population at hand. And so if you're dealing with, say, for example, a lot of travelers into an endemic area, then they're going to be prone to primary infection and a lot less likely to get hemorrhagic fever. If you're dealing with a lot of indigenous people that have been bitten multiple times and had recurrent disease, the incidence is going to be a lot higher. But I can't give you statistics on that, but a relatively high percentage of people that are native to an endemic region will get. I'd probably say at least 25. I bet 25% or higher of those persons would get hemorrhagic fever. But that's an educated guess.